So at this point, I'm ready to introduce our speaker. And our speaker looks like he's ready here. He's built quite a setup here. Our speaker this morning is Charlie Hamlin, and his topic is entitled Mortality, Morality, and Honor, the End-of-Life Paradigm. So we're looking forward to that. Let me give you a little information about Charlie. Charlie's on the National Board of Compassionate Choices, and he also serves on a state board of Compassionate Choices. Charlie's got a bachelor's degree from Yale. He did his medical education at Dartmouth in Columbia. After serving in the United States Air Force, he opened up private practice in Denver as a hand surgeon in 1976, and he retired from that just a few years ago, back in 2008, Charlie?
2 years ago.
2 years ago, okay. Charlie conceived and organized a pro bono clinic for Native Americans on the Navajo Nation, and he's the recipient of a humanitarian award from the American Academy of Orthopedic Surgeons. I know Charlie has one son in medicine as well, and I'm looking forward to hearing his talk. So if you would give a warm welcome to Charlie Hamlin.
Ray, it's nice to be here again. I have been to a number of your meetings and I find them well organized, well attended, and always of interest. If I seem distant or rude or rough, almost knocking coffee over when I came in, AV is not my strength, and I'm so pleased that it looks like we're hooked up. This morning I want to take you on a trip in a short enough time that we can get back and have some interactive conversations, you with each other, and I'll be glad to be involved. The trip I want to take you is not one most people think of. I want to take you on a trip that's not linear but circular. Why would I show you probably the most famous drawing in the Western canon of art at the beginning of this trip? Vitruvius was an architect in Rome, and Michelangelo did this drawing hoping to incorporate all elements of man and the natural as well as spiritual world. And even though we think linearly, surgeons worse than anybody else or better, you have a target, you want to get there, and you want to move on. I want to encourage circular thinking, because in our society and in this wonderful country we live in, it seems to me there's always a chance to fall on your face, and there's always a chance to get up. So think of the circle representing the cosmic and the divine, even though we recognize a lot of times our lives are pretty square. These are two iconic paintings by an abstract painter, Kenneth Noland. I like to say that life is not a long, flat table where we go along and suddenly fall off and that's it. We're constantly circling back into ideas and behavioral patterns. I'm obviously going to talk a little bit about some of the last circles. So am I another Dr. Death? No, my mantra is to grow older, die young, as late as possible, and plan on it and plan for it. Now, if this is my mantra...
Got one thing showing up there you probably don't want, the little square.
Yeah, I have no idea what to do with that. I'm so fortunate to have this working. Here's a friend. So if my mantra is that, what is my wish? My wish is to write my own last chapter, and when it's read a long time from now, to have it be recognized as a work of nonfiction.
Hey,
Yeah.
all right.
There.
So this is it. That's my wish. And is this something I should be afraid of, or you should be? Absolutely not. One of the great American patriots, Oliver Wendell Holmes, he was from Massachusetts. He was a poet, he was a patriot, he was a jurist, ultimately a Supreme Court judge, said, if you want to hit a bird on the wing, you must have your mind in focus. You must have that bird in your mind's eye. And every great achievement is a bird on the wing. I use this because what I think today about my mantra and my wish doesn't have to be something that I intend to be on an epitaph. We can change our minds anytime we want in this land of ours, and we can change it personally, and we can change it within our family, we can change it in our doctor's office, and with legal counsel. So I want to encourage all of us not to be afraid of something that seems meaningful now and might change, because every great achievement is a bird on the wing. If I get too long-winded, and I can find you one wonderful article, I refer to you to Atul Gawande, who's a surgeon in Boston, but who's probably the finest, most articulate medical writer working today. And he publishes in New Yorker magazine, and on August 12, 2010, he wrote a piece of poetry called Letting Go. So if you have any need to read something brief and wonderful, go there. Is this a time to talk about this? I have 6 grandchildren. Is it time for me to talk about it with those grandchildren? Absolutely. This is a giant issue. It's divisive, and I think it's going to be a major civil rights battle in the next 10 to 15 years. It's a big issue because they've done very serious studies, and the result of this study tells us that it is indeed a big issue, and that Ponce de Leon did not find the fountain of youth yet, even though medical science has done a great deal and life expectancy is much higher for me than my parents. It's not going to be easy. Right now, those of us who want to deal with chapters and recognize there will be a last chapter are kind of like the zebra in a herd of horses. In 2010, Gallup, great pollsters historically, whether you like their results or not, part of our American fabric, the most divisive question they asked were about end-of-life issues. And we're talking about the right of an adult of sound mind to be able to have choices at the end of life that are theirs alone. 45% it's morally acceptable, 32% it's morally wrong. This was the most divisive question groups that they asked in this poll. And this is what it is. The right in adults of sound mind to exercise choice and control for themselves at the end of life. The painting you see on the right is by Jacques-Louis David, and it hangs atop the grand staircase in the Metropolitan Museum of New York. And it is called Death of Socrates. And I want to remind you that Socrates was not poisoned by the hemlock. Socrates was offered a choice to accept the hemlock, or what people thought he would do, abandon his students and his state. And Socrates embraced his teachings and the independent minds of his students in his home, and he graciously accepted the hemlock. And you see here, he's doing just fine. It's his students that are gnashing their teeth and beating their heads against the wall. So I like to point that out, that Socrates, despite the story of hemlock, correctly embraced this based on his principles, his belief, and his choices. Do these choices make a difference? This is about 2 years old, this poll. Greater than 70% of Americans believe that terminally terminal ill patients should have the right to self-administer a lethal medicine to achieve a peaceful death. 70%. Statistics are what they are, I admit that. And when people embrace the medical profession, which still in some segments has a group that hold them in high regard, said yes, doctors should be allowed to help the terminally ill, even if it hastens their death. The word is compassion. When the word is suicide is used, statistics drop significantly. And we're trying to get rid of the word suicide in the context with which we're speaking about today. And I think that the courts and the public recognize that people who are terminally ill indeed are not suicidal when they're looking for compassion and help. They are dying, and providing support for them, compassion for them, choices for them is not assisting suicide. Rather than physician-assisted suicide, I'm going to give up that now for physician-assisted death, or death with dignity, or compassionate choices. Anything you want to use, but I'm not going to use suicide. In our society at this time, though the zebra is getting a little better and more clearly defined, there are three areas where there's a pushback in the fabric of our lives. Sanctity of life, a slippery slope, and what medicine can do. How many people today here are Catholics? Great. I completely respect that wonderful faith, and when I make a few points about some attitudes, it is made respectfully and based on published data, not any criticism of that wonderful faith. The sanctity of life, represented here with this majestic painting by Caravaggio, is held in such high regard by the Catholic faith that in Seattle a year ago, with the Conference of Bishops, recognizing that there was, particularly on the West Coast, end-of-life legislation, Oregon 17 years, Washington State 2 or 3 years, and now Montana, came out with a statement saying all patients, including those in the so-called persistent vegetative state, be provided with artificial hydration and nutrition if such care could extend life even indefinitely. That's strong, strong words. And in their ethical and religious directives, they went further, defining their faith, saying that virtue is protecting and prolonging life over all virtues, overruling patient concerns about their quality of life. This is a quote, and I don't think I've made any errors here, but that says something about what I think in medicine and the human race about compassion. Further, patients experiencing suffering that cannot be alleviated should be helped to appreciate the Christian understanding of redemptive suffering. Now, I think that has more merit than the first line, because everybody has a little pain every day. When I used to lecture to the residents, that was one of my slides, that everybody has a little pain every day. Pain is the emotion nobody wants, the sensation, but it guides us, it protects us, it helps us recognize our humanity and maybe our arthritis as well. There's an irony to the strong Catholic faith here with these remarks, because at the present time, more than 40% of the hospitals are beautifully run and organized by people of the Catholic faith, from caregivers to administrators to nurses to businessmen. And so that's a tremendous involvement of this great faith in our medical care. I think it's higher than 40%. And there's an irony and maybe an anxiety to that when you go a little farther and consider things like, well, just vasectomy and tubal ligations, perhaps. And there's also a little bit of hypocrisy if we have a little wit that says, if we're going to a better place, and we embrace the idea of heaven, if not hell, why are we so afraid of the last chapter? That's a provocative question. It's not rhetorical. I don't know the answer. When I graduated from Columbia Medical School in New York, I was not read the Hippocratic Oath, but the first English translation way, way back said, quote, "I will not give a lethal drug to anyone if I'm asked." In 1960, in Boston, an ethicist rewrote a newer translation that says, "I will remember that there is an art to medicine as well as a science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug." So does the idea of our medical community getting involved and offering a different kind of compassion make sense with these thoughts? Death with dignity, physician-assisted death. Just let's go back one step. Personal choice. America is based on freedom. Personal choice for the last chapter. And compassion for me is to understand suffering and hope to do something about it. That's what I thought I learned in medical school, even though as a upper extremity surgeon, I did not deal very often with end-of-life issues. This harkens back to going to a better place, whether we're a Hindu in India and think we're going to be reincarnated, or if we think we're going to heaven. Isn't it important to have a destination? What would it be like if we had no more death, if we could capture the sun before it went down? There wouldn't be any need for progress or art. We wouldn't have all that much to do because there wouldn't be any deadlines, would there? And yet, in the greatest of ironies, we'd have endless eons in which to do it. And action would lose its purpose, and I think time its value. The second criticism of some of the things we believe in, or I'm hoping you will come to believe in this audience, is that if we step in and permit freedom, and then, based on that choice, provide any kind of assistance to make those goals and wishes come true, that this slippery slope will lead us to taking advantage of certain groups. And you can read here that people say the elderly need their lobbyists, the uninsured need advocates, the uneducated, the minorities, the poor. I don't have gender issues in here. It's the men that need protection, I think. They're not as smart as the women. But this is the idea that the slippery slope will take us someplace we do not want to go. There is absolutely no evidence in many, many years in the Netherlands, and I'll come in a moment to data from Oregon, which is our best model in this country. There are some say that it might be a reverse slope, and instead of taking advantage or not caring properly for the elderly, uninsured, etc., that it's the white and the wealthy and the afraid that will be able to use these laws and not the other groups. The final argument, or among the major arguments, is the idea that medicine can solve all the problems for us. This is erroneous and an anathema. Why, for example, is palliative care only a recent specialty in the medical arena, and indeed an essential one? Where has it been all this time? I referenced Colorado Senate Bill 102, which was passed in 2006 in our state. I was on a committee that worked to get this done, and what it says simply is that doctors cannot be indicted for providing care to the terminally ill, even if that care hastens their death. It's a simple bill like that, but it took a little bit to get it passed. And I think it was based on many, many people who needed compassion and help being under-medicated for fear, whatever. It's almost amusing to think that someone is so uncomfortable that they can't get enough pain support for fear of maybe becoming dependent. But that was one of the arguments. It's interesting, I'll just tell two little stories about that Senate bill movement. We had at that time a Catholic governor, and he gave us 15 minutes, and we went, and he then spent an hour with us and said, if I can get this bill on my desk below the radar, quietly, I will sign it immediately. Both my parents had a wonderful, helpful death in hospice. And the second interview took place with the Archbishop in Colorado. And we had a patient with us who was close to death. And he told this wonderful man that he would not have been in his office if the doctors hadn't given him enough medicine, because he was ready to commit suicide. He used that word with the Archbishop, because he was so miserable, and instead he'd had 6 wonderful months because of proper medication. And the comment by the Archbishop was, you mean that a bill like this might prevent suicide, not be suicide? I think it's worth talking and circling back to when I talked about pain being the sensation nobody wants, to have you look at this slide and think a little bit about what real pain is in the human condition. The man on your left is a guy named Greg LeMond, who was a Tour de France winner 3 times, preceding Lance Armstrong. And he's got cramps and smoke coming out of his quadriceps and his legs. His lungs are on fire. He's having trouble breathing, and you can tell from the expression on his face that his endomorphins are pumping out, and he is in a great mood to press on and win this race. The man on your right in the lower part of the frame is probably also not in pain. His neurosynapses have been interrupted. He may be at death, past the moment of death, but the real pain in this picture is the man on the upper image on your right. And I contend that in the human condition, the psyche and the spirit take the greatest brunt of pain. I used to tell my patients that pain is a psychological reaction to a physical stimulus. And if you had 5 people with the same assault on their body with a surgeon's knife or a fall from a bicycle, you'd have 5 different reactions. And this is the awareness of pain, and the integration of it is something that cannot really be treated completely by medicine. Medicine does have some strength. I used to say, and still do, that if you're a member of AA, it's the best medicus in the world. AA being assets and access. But that's about 3% of our population are strong members of those 2 groups. And even if you have AA, intensive care unit, probably more than 5,000 a day, chemotherapy protocols, there is no limit to those. Some of them absolutely wonderful. Surgery, who knows? Those are pretty high price tags. And that's what medicine is good at, illness, not wellness. But ultimately, the owl calls our name. What are we not so good at in our society? As you look at these quotes, the first one is from the great poem by Lucretius, written 2,000 years ago. Against other things, it is possible to gain security, but when it comes to death, we human beings all live in an unwalled city. And the second is well known to many of you, Steve Jobs. in a speech before he became really ill, poetic for a man who was so tough and tenacious. No one wants to die. Even people who want to go to heaven don't want to die to get there. Yet death is the destination we all share. My profession struggles with this. This is a study done 2 years ago by a person in Boston. And they took a group of people with one of the worst cancers, lung cell, small cell cancer of the lung, people with advanced disease, and they broke them into 2 groups. In one group, they provided palliative care and counseling about end-of-life choices. And the second group, which had the regular protocols and as well had counseling and the conversation, reported better quality of life and less troublesome symptoms in the time remaining. Their physicians probably had better quality of life and less stress and had a better appreciation of their patients' wishes. And the families, both during and after, had less guilt and depression from having engaged in this dialogue. And if you believe that stress is a great part of life and the problems of life, group 2 also lived a little bit longer. Another study which I like to quote and make a little fun of is by a very bright woman, also in Boston, Master of Public Health as well as MD degree, who did a survey by mail, I guess, or internet, of over 4,000 caregivers, gerontologists, oncologists, people who are dealing with the elderly and the very ill. And she questioned, when do you, in your practice, get into things like serious prognosis, accurate prognosis, wishes for do not resuscitate, a need for consideration of the wonderful hospice system, and what are your wishes for way, time, and site of death? And this bizarre summary by Dr. Keating, most physicians report they would not discuss end-of-life options with terminally ill patients who are feeling well. There will be time for that later. This is some kind of dark comedy, I think. Be advised, talking about dying won't kill you. And I'm embarrassed that medicine, when they behave like this, don't act like this. There's a wonderful editorial in the Wall Street Journal 3 months ago by a associate clinical professor at family medicine in California that recognizes and addresses the fact that doctors are a lot more candid about accurate prognosis, the cost, both of how well you feel as well as how your bank account feels, to heroic measures and chemotherapy, whatever. And doctors seem to die differently, so why can't we as a profession be more compassionate and helpful? And this is verified in another study published in February this year, a poll of a couple of thousand doctors who admitted that the pyramid was upside down in many ways, and that they had framed a prognosis that was more positive for whatever reason than was warranted. I think things are getting better, though, because of groups like this, people like yourself. Study in 11 by the Regents Foundation, 96% of physicians believe it's more important to consider quality of life rather than prolongation. And you never talk about money with healthcare. God forbid that that's part of the equation. But we spend a great deal not extending time or quality. I think this topic I'll talk about for about a minute and a half is not the 400-pound, but the 800-pound gorilla in our room. One of the greatest people alive in my lifetime, I think, is Sandra Day O'Connor. I've read about her, and I think she's a great, great person who walked a tightrope in her lifetime that moved through periods in our society that were the most monumental in terms of change. You might be reminded that as a graduate of Stanford Law School and on the Stanford Law Review, she was offered secretarial jobs. But she retired from the court because her husband was ill, and he was gone from her cognitively in 3 months and gone in 6 months. And she wrote this op-ed piece very bravely for the New York Times in October, that Alzheimer's is a degenerative disease that is 100% incurable and 100% fatal, which robs its victims of memory, judgment, and dignity, leaving them unable to care for themselves and destroying their brain and their dignity, often depleting the resources of their caregivers and their families, emotionally and financially. That's a brave statement from someone who cannot help but be a public figure. And baby boomers are becoming part of us every 8 seconds, and medical science tells us that every 5 years our chance of dementia doubles. And I think that one of the biggest shifts in my advanced directives was to let my family know that when I don't know them, I don't want any nutrition. I don't know who my grandchildren are, and my wife of many, many years. That to me is a separation of quality that I'm right now unwilling to accept. Remember, every great achievement is a bird on the wing. So I can change my mind in 6 months, whatever. But I'll say you that is far more important to me than whether I have low back pain or my artificial knee, which I don't have yet, is wearing out. This is the computer that defines life. A wonderful professor of medicine at the University of Wisconsin tried to address what is a good death. First of all, it's being in control. That, I think, is number one. Knowing what you want. And being able to share that, being comfortable enough to share that with your partners, your children, your doctor, your pastor, your attorney, whatever. Being comfortable, being in control, having a sense of closure, making most of the relationships we have, and having family involved. And these two poignant pictures sum it up in many ways. These are accurate photographs, they're not Photoshop. The picture on the left, as you can imagine, is in an intensive care unit. And if we believe that the first sound or noise we hear or feel might be our mother's heartbeat, there is absolutely no place on the left for a heartbeat or for words such as forgive me, I forgive you, I'm sorry, or I love you. On the right is a woman probably with her favorite wrap and shawl on, looking through a Dreamweaver. Out the window, probably her cat has just left her, and hopefully one of her grandchildren is about 5 feet away. Which one? So I talked about the end-of-life paradigm, and I'm going to change the topic now before I change it once more and call this Choices at the End of Life. And let me talk about 2 brutal moments in the history of end-of-life issues that we need to be reminded about, how far we have come in the matter of 3-4 decades. New Jersey, Karen Ann Quinlan, 1976. High school student drinking with her friends, took some Valium, tired, lay down. And went into a coma which became a chronic vegetative state. And this was a young woman from a wonderfully strong Catholic family. And there were no rules and regulations. This was a difficult time in the beginnings of the movement, and this woman was in a chronic vegetative state for 8 years. And her father, who was her assigned guardian and was a very wonderful, strong Catholic, dealt with this over the years, and finally, with his priest and his church and his doctor and his conscience, was able to withdraw artificial hydration and nutrition. 8 years, I believe. And this was sad, not bad, sad, but the good thing and the silver lining in this was it was the first case that really brought into the public light concepts of theology and bioethics and euthanasia and legal guardianship and, I think, civil rights. And as I said before, I think this issue is one of the great civil rights platforms which this country will need to address as we get older and live longer and don't die S&M, sudden and massive. We have chronic debilitating disease more than rampant infections. So from this case came bioethics committees at our hospitals and, most important, advanced directives. Terry Schiavo, this was 17 years in Florida. This was a terrible moment in our more recent history. But 17 years divided a family which had gotten along well and destroyed some reputations all the way up into our Senate, frankly. And that was a tragic case. That was probably a chemical electrolyte imbalance from someone whose eating habits were terrible. Just to go over briefly, as towards the end, and we get you involved, about what the movement in this country was, you need to know that in 1920 in Zurich, the first end-of-life movement began with a group called Dignitas. And in Zurich, that organization still exists, and one can still go to Switzerland and get help at the end of life. It then moved fairly comfortably into the Netherlands, but in this country it was a difficult movement, and in the late 80s, a state senator in Oregon, Frank Roberts, tried for 2 or 3 sessions to get a bill to the legislature, and was unable to get it out of committee. And poignantly, he developed bad cancer and had a harsh death without help, dying in his home, luckily in '93. Interestingly, his wife at that time was governor, and there was such respect for the process and the education within the citizenry of the state that his wife, Barbara Roberts, was able to get a voter initiative on the ballot, and it passed 51 to 49, a death with dignity law. Now this is '94. It's sad to remember what also was going on at that time. The AIDS epidemic had struck, and in the state of New York in 1994, more people died of HIV than had died in the whole Vietnam War, which I think was 56,000 people. And in Washington, a group without legal precedents stepped up to help people who were HIV infected and worked with them in a very careful way. Eligibility criteria, guidelines, safeguards, and volunteers to attend death. And a medical model evolved, which was very helpful to the Oregon movement. It still, however, took 3 years for this to become law in Oregon, from the challenges by the court. And this was a decision by the United States Supreme Court, where it ultimately ended up. Our holding permits this debate to continue, as it should, in a democratic society. And so with a ballot initiative, it passed at that time, finally, 60 to 40% in 97. So we have some data on what's going on with death with dignity and end-of-life choices. The slippery slope argument, we should be aware of that as we look at these demographics. Median age 70, not minorities, no gender difference. Education, most people were not taken advantage of because of lack of formal education or language. Tremendous number had painful malignancies. It wasn't heart disease or infected joints, certainly not dementia at this point. And almost 88% used the wonderful hospital system, and we didn't pick on the uninsured to get rid of them from our population. And this is a small graph, and what it demonstrates is that though there is an increase in users as represented by the small green bars and an increase in prescriptions, and I'll go over that in a second, it hasn't grown that much with numbers when you take into the fact that we have an aging population with more chronic disease and people are more aware of what's to them. It's not an exponential curve at all. And the reasons people want to have choice at the end of life and get their house in order, losing autonomy, almost 90%, can't engage in things that give them pleasure, losing control of bodily functions, burden to friends and family, down to 40%, inadequate pain control, happily down to 24%, and also wonderfully comforting, people were not working on end-of-life issues because they were destitute. There are social services in Oregon, and financial considerations were not a choice. People always ask me, what are we talking about? I talked about what is it. Now is how to do it. In the history of compassion and choices, there is really a very serious and step-by-step process to gain a prescription of the drug of choice, which is Seconal, barbiturate. You have to be advised of all your other choices in a serious medical forum. You've got to make a couple of verbal requests to your team, at least 15 days apart. This has to become a written request that cannot be witnessed by anyone who's a caregiver or a family member, and a doctor cannot administrate a terminal dose, as Kevorkian did. Despite his strong beliefs, that's active euthanasia. This is passive euthanasia. So the patient is in charge of this decision and exercising it. A couple of words about our government and what we're doing besides the states of Oregon, Washington, and Montana. This great slide introduces the famous charade of the Affordable Health Care Act, in which the Democrats caved in and withdrew a bullet that said, if a doctor takes the time to have a conversation with his patient and their family, they can be reimbursed. My middle son is a family practice physician in New Mexico, and I asked him specifically, and he said, if I spend a half an hour, we have a relative value code is how doctors get paid. He said, I would get paid another $37 for taking a half an hour with a family to discuss their wishes at the end of life. And that was what that bullet said, nothing more, absolutely nothing more. And this was picked up by a woman in New York, Betsy McCahey, who I think was lieutenant governor, and then of course the famous star from Alaska, and I do think she's a star and ought to stay there, out there in the celestial bodies. This is a direct quote, accurate quote. "My parents and my baby with Down syndrome will have to stand in front of Obama's death panel so board bureaucrats can decide based on subjective judgment on their level of productivity in society whether they are worthy of health care." How could these steps take place in this country of laws and facts? Nullis in verba is the motto of Isaac Newton's Science Foundation in London in the 1500s. It says something like, "Don't believe what they say." But 30 to 45% of Americans believe this rhetoric, and it was shameful, I think.
Well, that's why they say it, isn't it? I mean, that's why they say outrageous things, because so many people don't ever question.
Well, we used to, when you and I were young, it was 30-second sound bites. Now it's about 7-second sound bites. My wife, who's wonderfully optimistic, said, don't underestimate the voters. But they don't have data. We'll get some involvement from you in a moment. I'm on the home stretch here. Another thing in government that took place in the Affordable Health Care Act took place in January of this year. One of the great ones I think we all approve of is that our insurance carriers have to pay 80% towards health care, not less. I think that's a good bullet. Another one was an independent at-home organization. The creation of these to get caregivers to come into the home. How are you going to pay for anything in the Affordable Health Care Act? Well, you can imagine the studies and the things that go on if you're in the hospital or extended care facility. So the idea of being independent at home with caregivers who are awarded to provide this care, I think, is a good bullet. And finally, if this goes on in 2014, there'll be an independent payment advisory board that makes recommendations on cost savings. And when this comes up, there'll be another scream that we're rationing health care. And this says in the bullet, it is expressly prohibited from taking any action on rationing care. And yet, care has always been rationed in this country and elsewhere. There are different entry zones for AA, assets and access. Just to tell you how spoiled I am, I'm dealing with a problem with stenosis on my neck, and there's a very famous surgeon at Stanford, and I called yesterday, and I'm going to see him Tuesday morning. And if probably someone else called, they say, "We'd love to see you in early July." So that's what I'm saying by life is not fair. We know that. But when you read the bullets in the Affordable Health Care Act, and I have, you can do it very short, you don't have to read 2,700 pages, maybe 60% of Americans now would like to see this repealed. And of those people who want it repealed, they're in favor of 70% of the things in that Health Care Act. And I, as a doctor, tell you I am totally for it, and if we don't have something on the books, you can't make it better. And I predict the Supreme Court will go 6-3 to uphold, but I don't know anything about that.
To uphold, did you say?
I'm sorry?
To hear you, 6-3 to uphold.
I think so. I think Stevens is going to cross, and Roberts wants to be loved, and he's going to write the majority opinion. And there's a fabulous article just in last Sunday's paper about this. I'll just diverge for a minute. It's not in Sunday's paper. It's a month ago in the New York Review of Books, wherein a legal scholar makes the point that we already have the mandate, because it's a federal mandate, that people cannot be turned away from care in the emergency room. It's a federal mandate, so they already have health insurance. So why can't we say, okay, now we got to figure out a better way to pay for it, which is that. But I can say that, and hopefully no one's going to shoot me. That's the nice thing about this country. Cost. We don't know it's the last 3 months, but 25% of our major mammoth Medicare budget is for the last 3 months, about $60 billion. That could be used for a lot of nice things. So what are your rights now? How do we stop this juggernaut of American medicine that can overwhelm us and our loved ones at the end, as represented by this bison breaking through a small fence? Everybody has the right to reject their medical care, their sound mind and adult. And that includes hydration, nutrition, big things like dialysis, surgery, blood transfusions. That's everybody's right in every state. And you don't have to be terminally ill to do that. You do not have to be gobbled up by a big medical system if you and your family and your loved ones decide it's not what you want. And our people believe this too. 84% in a 5-year study with the Pew Charitable Research let patients decide. I think that's an unalienable right. And it goes back in our legal DNA too. The first big case we know about in our law courts, and we are a country of laws, was the great jurist Cardosa, when he was New York Court of Appeals, represented a woman who requested not to have heroic mutilating surgery if the exploration of her abdomen proved devastating. And indeed it did, and the doctors didn't listen to her. And so this one small case in 1914, Cardosa, every human being of adult years and sound mind has a right to determine what shall be done with her own body. I don't want to be a one-trick pony, so I want to tell just one other story. Devil's advocate. A great paleontologist from Brooklyn who ended up at Harvard had a diagnosis of an abdominal mesothelioma made in 1985. And the literature, and he was a scientist, said that he had about 8 months to live with heroic treatment, aggressive treatment. And he knew about the long curve at the end of these means and medians. And he decided that he would do something about it as best he could, and he lived from 85 until 2002 with surgery and chemotherapy. And this is a great quote, I think, for the opposite side, and it represents just what I'm saying. This was his choice. It has become, in my view, a bit too trendy to regard acceptance of death as something tantamount to intrinsic duty. Of course I agree with the preacher in Ecclesiastes that there is a time to live and a time to die. And when my skein runs out, I hope to face the end calmly and in my own way. For most situations, though, I prefer the Marshall view that death is the ultimate enemy, and I find nothing reproachable in those who would, as Dylan Thomas said, rage mightily against the dying of the light. And all I say to everyone I talk to as I ride this horse around in my dotage is choice, choice, choice. Whatever it is, make a choice and have it honored, and have the right, legally and emotionally, to have it honored. Ray and someone on your audience talked about living wills a moment ago. Advanced directives are the best because they're the most complete. A happens, da-da-da. There are two great sources better than advanced directive living wills, and those are 5 Wishes, which is an organization in the southeast Tennessee, I think. Google that up. And even better is Compassion and Choices, and because they break down advanced directives into every state, so it's absolutely legal, and it will take you 15 minutes to fill it out. But if you do so, and if you join the wonderful organization which you represent here, you can get these put on a little jump drive or a little CD. And that's quite wonderful. Did you know if someone you cares about has a DNR wish and the paramedics come, that they won't honor it, that they are not allowed to decide? That has to be a doctor, so they will pound on her chest or start his IV or whatever. Nothing perverse in that, it just represents the imperfection and the difficulty of our law. So I encourage all of you, compassionandchoices.org, advanced directives, state of Colorado, and fill it out. It's the best thing you can have. It's your wish. And we all read Homer at some point in our lives, and this is the great moment when the sirens come to seduce Achilles, And he's tied to the mast, as he instructed his sailors to do. That was his advance directive. And he then said, let me out of here. These women are beautiful. I love their song. And they said, no, you have an advance directive. We want to honor it. And indeed, he ultimately got home. But this story goes back to every great achievement is a bird on the wing. When am I not me? When is my directive not what I want? It's a bird on the wing, but I'm going to still chase it. I can go through this quickly because you know all about compassion and choices. And your organization and mine doesn't violate any of these prescribed set of customs at the end of life. Reaffirming our faith and having it respected, repenting our sins. I like to say I've made all the mistakes, but if I hadn't made them, I wouldn't be here now. And I'm quite happy with where I am right now. So forgive my sins, of which there are many, over 73 years. Let go of the worldly affairs. Last words. I'll say just a couple of things about hospice. The woman in the upper right, Cicely Saunders, was a great physician from London and started the first hospice there in the 40s. And because of gender problems, she came here and was appointed dean of the Yale School of Nursing rather than the Yale School of Medicine, where she belonged, but did start the first hospice in this country in Branford, Connecticut. Her moniker, we do not have to cure, to heal. She was not an advocate of doctor-assisted death, but she recognized it was part of the dialogue. The second woman, Elizabeth Kubler-Ross, on death and dying, one of the great books, talks about the 5 stages of death of a loved one of yourself, from denial, anger, whatever. She ended up her career, interestingly, at the University of Colorado, and I wished I'd met her. And also, interestingly, she was born in Zurich, which is where Dignitas started in 1920. Hospice is a little bit of a problem. We have a wonderful new hospice facility in Denver. As you know, it's supported by Medicare. 84% of the bills are paid by Medicare. You've got to figure you have 6 months to live or less to be accepted. That's a soft number, and you don't have to exercise that option. And you have to accept the fact that you're not going to be rushed to the ICU for chest pain or whatever. There's an acceptance to hospice care. And last year, 42% of the people who died in this country died in hospice nationally. That was different, as you remember, from Oregon, where more people die at home. Interestingly and sadly, 22% of people die in ICUs, despite the message we're given by the reality shows on TV that everybody gets over a heart attack. Those things just are not true in our medical environment. And the problem with America is the goose that lays the golden egg is capitalism, which is wonderful, but 40% of hospices are now for profit. The cost for profit hospice is almost 30% higher. There have already been some lawsuits and settlements in this wonderful, wonderful organization. So this is a complicated landscape. Is there any chance, whether we're zebras or horses, we can be of one mind? Absolutely. It's a movement that's not going to stop because we're getting older and we're going to be in charge of ourselves. And if you're a philosopher, Goethe was one of the greatest scholars in the Western canon. My brother, who died in hospice in New Haven last January, was perhaps the world's greatest Goethe scholar. He's professor of comparative literature. This great quote from Goethe: "As long as you are not aware of the continual law of die and be again, you are merely a vague guest on a dark earth." And for more modern readers, Hemingway, whose death I don't approve of, shooting himself with a shotgun with real depression, and a father who killed himself as well, made this wonderful quote: "The worst death for anyone is to lose the center of his being, the thing she really is." Hence my advanced directive instruction about Alzheimer's. And finally, if you're listening to the music of your children and grandchildren, the Grateful Dead, from a song, "Standing in the shaft of light, rising up to paradise, I know I'm going to shine."
Yeah.
And I do not think I'm a Dr. Death. Acceptance of death when it arrives is one thing, but to allow it to upstage the joys of living is ingratitude. This Renoir painting at the Phillips Collection, The Boating Party in Washington, D.C. And a final quote by Rilke, the Austrian poet: "I live my life in widening circles that reach out across the world. I will not complete the last one, but I give myself to it." So I went from the end-of-life paradigm to mortality and morality and honor, to ending up saying honor choice at the end of life. Let us know what those choices are. So now I'm glad to turn this microphone over to any thoughts of you. Thank you for your attention. Yes, Sam.
I'm interested in that 1914 ruling by Supreme Court Judge Cardozo in affirming that people have right to control their own body. Is there a specific law that says I have that is being referred to? Because I don't understand how we can have a law that makes that legal and then have other laws that declare it illegal.
Yes, the question, of course, is what rights do we have? This case, Cardozo was then head of Second District Court of Appeals in New York before the Supreme Court, and this had to do with surgical consent, which is now a very carefully monitored and developed legal document. So those rights that would occur in that case cannot occur now because these things have to be in the surgical consent. And it's everybody's right to challenge adherence or lack of adherence to a surgical or procedure consent signed by the treating physician and the patient. So in your case, this is a very well-regulated field now so that mistakes aren't made, such as occurred at New York Hospital in 1914.
I can address that a little more with a little more specificity. It's quite clear now in American established constitutional interpretation that the right to your body is the right to your body, and the reaffirmation of that was the Nuremberg trials on medical research. Where all of these issues arise is where somebody's wishes aren't known because there is no directive, and they do not have a surrogate who's appropriate for making a decision for their body when they can't. But that aspect is settled law now.
Thank you.
Yes, sir.
Hi, my name's Bart Windrum. I've written a book called Notes from the Waiting Room, Managing a Loved One's End-of-Life Hospitalization, which happens to be for sale on the Compassionate Choices website bookstore. I know that you all who run Compassionate Choices give a lot of thought to language, and language is really, really crucial. I'd like to take this opportunity to ask you on the national level to consider including a different piece of language along with the phrase you've chosen, which is physician-assisted dying. And I subscribe to Tom Preston's language. He's a doctor who wrote a book called Patient-Directed Dying. And I find a lot more value in that term, or citizen-directed dying, because in my experience, that led me here with the 3-week terminal hospitalizations of each of my parents, only 15 months apart, despite our advanced directives. I understand the slippery slope. And from attending meetings here in this chapter for a year or more, the questions that have arisen indicate to me that we all struggle with the slippery slope. What happens if we end up in a hospitalization that becomes terminal and is about to become a train wreck? And my experience of the answers that doctors from even hospice have provided to us is that it's very narrow, because doctors are too busy doing their job, and they can't talk to us in a manner that will really impact us with long-range planning. So I find a lot of value in the term patient-directed dying, because it puts the onus on us. It places the ultimate responsibility on us as individuals. And my concern and my experience of the notion of physician-assisted dying is that there's always somebody else to lean on. There's always medicine out there to save us. But we know that medicine is very slow to respond, because nobody wants to initiate the talk. Right? And this is the way it plays out right now, despite all of our work. So I want to ask you, it's almost a plea, to consider this sort of terminology.
I think you said it better than I can. I think that in all phases of our lives, communication is probably the most important. Consider how hard it is for many voters to deal with ballot issues, just to answer that. I think writers are better at it than lawyers. I quoted 3 brilliant writers at the end, a songwriter, Ernest Hemingway and Goethe, who said things poetically that were more immediate to me than a legal document. But it's a work in progress, a bird on the wing, and I support what you say. I have no other comments. Someone else might. But communication is everything in life, and that's what advanced directives are. Yes, sir.
I have to agree with you. In 1983, my mother asked the doctor as she was leaving to go home to die, "What do I do when I want to die?" He backed up against the white wall and he matched the color of the wall. He said he couldn't talk about it. I said he could. He talked with us. He said, "The only thing I know is to increase the amount of MS that she's getting until her heart slows down and she goes to bed, sleep, and dies." She came to my home and stayed for about 2 months. And one night she said, I want to go now." I talked with her about the options. I said I couldn't put a plastic bag over your head. I couldn't strangle you. The only thing I know is to do what the doctor said. I was under my mother's direction. I increased the medication and kept increasing it, and he kept writing new prescriptions until we finally ended her life. I think that's the way it should be. There's only one thing missing, and that was that though we had the help of hospice, I can't remember that there was anyone to be my mother's advocate, to be sure that there was nothing going on in the dynamics of the home that might have made her want to die sooner than she might otherwise have wanted to die. The concept of directed termination of life makes far more sense to me than having to commit suicide, assisted suicide, while I still can, but I still would like to live until I can't commit the suicide. I want to be able to control when it happens. My mother did.
I would like you to say more about your what you said about your own advanced directives in terms of Alzheimer's, because my understanding, maybe I have a misunderstanding, is that a person with Alzheimer's can be completely healthy, but their brain is not working. So, in terms of not being fed and, and given hydration.
The question is specifically with Alzheimer's, what can I do and what can society do? First of all, Alzheimer's is poorly understood, and it's probably overdiagnosed now, but it's the most advanced form of dementia, and it has to do with amyloid deposits in the brain, we think. We have no treatment, though there are some drugs which seem to diminish the formation of amyloid. It's a sort of beta protein that's made, but that has no play out in Alzheimer's. Most people with Alzheimer's die of infection, aspiration, pneumonia, probably number one, kidney disease, urinary tract infections, and the care is complicated and expensive. In my directive specifically, I say that if I have entered a state of Alzheimer's and do not recognize my family, I wrote this handwritten out, I would ask for the cessation of nutrition, and I wanted ice chips and some oral sedatives so I wasn't restless. The reason I did this is when you stop eating, you're hungry for at least a day and a half, and then your body goes into something called ketoacidosis, and you're no longer driven by hunger. This has an immediacy for me. I walked into my father's hospital room the day after exploratory surgery, and the biopsy was back, and it was a non-resectable retroperitoneal sarcoma. And he knew he could have had palliative radiation, lived at least 3 months, burning out his GI tract. And he said to me, I'd like two things from you. He first of all said, what'd they find? And I told him, and he said, I was the only one in medicine. He said, that's the end of me. I didn't say anything, and he said, I'd like two favors. He said, I'd like this IV out, and I want ice chips and morphine. And he was uncomfortable and restless for a day and a half, and he lived almost 7 days. And that was obviously monumental for me, but I call his death brave, brief, and heroic. And my mother, who lived to be 92, spent the last 2 years of her life, probably with some CVAs, not dementia, in a nursing home in Rhode Island. And you could approach her and clap your hands by her ear suddenly, and she wouldn't respond. And she did not have advanced directives, and we were able to afford this care of a chronic vegetative state, but it was poisonous for the spirit of her family. Poisonous. So that goes back to the personal question and why my advance directives say that. And they don't say things like that in living wills, do not resuscitate. So I favor as many questions being answered, and if I want to change that in 6 months, I will. And all my children and my wife, my grandchildren, maybe not all my children, sounds like a TV serial, know my wishes. And they smile. But the middle one who's in medicine, he knows I'm serious. It's a document. And I don't want to, that's a personal story. That's enough for that one.
So the end.
Quote the words again.
I'm sorry?
Can you quote what you said again?
What I said,
To your directive.
I said that in the case of loss of cognitive function, so that I didn't recognize specifically wife, children, or grandchildren for a period of greater than 30 days, obviously this would come to a point where they said, I don't think he knows we're here. So it's not like it's going to happen like that. If you had a motorcycle accident, that's different. Then I wish all nutrition to be stopped, whether it's a feeding tube or whatever, and I wish ice chips and oral sedation. And it's a medical fact that you lose your hunger in about 2 days if you suddenly shut it off. Ketoacidosis, it's called. So that's what I said. And there's a question in the advanced directives that lead you to say, talk about cognitive skills. So it's not something you got to make up. You can go through the directives, which would take about 15 minutes, and there'll be a space for that. Yes.
So my concern for compassion and choice, especially after hearing these two gentlemen, is the responsibility that's laid on our family members for doing the right thing, lives with them and challenges them for a long time. There should be another source of people who, with their permission, can actually be those who do it, and that relieves our family members of this last piece. In your case, you have a son who's a doctor, so that probably is okay, but most of us don't. I wish that Compassion and Choice were organizing to have volunteers who would be this person in consultation with the family, but it's someone else who in the end does that last thing. And I look around this room, I mean, I'd be happy to do that for anyone, and I'm sure everyone here would, but maybe I'll outlive all of you. Compassion and Choice needs a younger group who we can all rely upon. And so what I'm wondering is whether our families, who are the people, our adult children who have this for us, could actually do it for somebody else, and your all's adult children do it for me, so this ultimate piece isn't stuck on the direct child and then caught in the dynamics, of that own personal family.
Yeah,
So I raised that as a Compassion and Choice project to really consider becoming involved in. Let us switch our adult children with each other.
I think the next step for you and all of us is for the medical profession to step up. And there's a right to know now law in California, a stricter one in New York, where a doctor is required in California to answer all questions once it's opened up, and they're required in New York to ask those questions. But medicine has got to step up in the sense that they're a little bit of a more neutral force than your oldest daughter or whatever. It might be hard for a friend. But I really put the responsibility on medicine to start the conversation with any patient. And it doesn't go to people who are 75 and stiff. Given the chaos in the highways, I'm going to try to get my 3 children to have advanced directives. None of them have a motorcycle or an airplane, but the highways, head injuries, whatever. So here's our noble leader.
Thank you very much, Charlie. That was an excellent presentation. Some of those words and images are going to stay with me for a long time. Thank you. By the way, one thing on your question here is that our board is currently working on what we can do in that direction.
Yeah,
Finding someone to cover medical durable power of attorneys, yeah. Vicki.
And also, we're working on arranging for a speaker, probably in September, for a talk that's basically caregiver fatigue. And we're very lucky in the Boulder County area. We live in a bubble, really. We have a lot of organizations that give respite care. But it's in other parts of the state and of the country where there isn't this acknowledgement and this awareness. But hopefully in September and in November, you'll get more information on both these topics.
Alrighty, I thank you. Our meeting is adjourned. If you want notification of future meetings, put your name and email address on the sheet in the back, and you will find out about them. Have a great day. Bye-bye.